Before we get started on today's episode, a quick introduction to VitalStream. VitalStream is a wireless wearable non-invasive hemodynamic monitoring platform designed to give continuous real-time physiological data so you're not relying purely on intermittent cough readings when patients are unstable, moving or in a non-traditional care space. So it uses AI algorithms and patented post-decomposition analysis to continuously measure blood pressure and advanced hemodynamic parameters such as cardiac output, stroke volume, systemic vascular resistance and fluid status, helping teams understand whether a patient is fluid responsive and what's driving the physiology. BHA Medical's VitalStream solution focuses really on getting that continuous non-invasive monitoring into acute care workflows, streaming real-time data to centralized platforms so clinicians can make earlier, better informed decisions. And for corridor medicine, where patients can end up in areas without usual monitoring infrastructure, the key issue here is misdeterioration between spot checks. So continuous trending is the point, reduce blind spots, supporting early recognition of hemodynamic decline, helping teams prioritize interventions when staffing and space are stretched. And for pure spot care, where we're interested in keeping the physiological story visible from first patient contact through transport, VitalStream is designed for rapid application, fit and calibrated and monitoring within 90 seconds with a low pressure finger sensor, so crews can follow trends in real time rather than snapshots. For more information, please head to the show notes or go to bha/medical.com and look at the VitalStream option there on the platform.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today we're looking at aeromedical medicine. So the concept of fixed wing retrieval, really exploring where physiology meets aviation with Dr. Ina Schmidt. So Dr. Ina Schmidt is a consultant anaesthetist, intensivist, flight physician, and president of ICARUS EV. And we're with her today really just to examine what truly changes when critical care leaves the ground. So drawing on Ina's experience, we're really going to examine the intersection of critical care, intensive care, and aviation medicine. Ina's really going to talk us through why aeromedical medicine should be regarded as a distinct speciality rather than simply just EMS in the sky. So together, we're going to explore the unique physiology, some of the operational challenges of patient care at altitude, from hypobaric hypoxia to environmental stressors to the complexities of monitoring critically ill patients in confined high noise environments. We're also going to examine the future of in-flight critical care, including the broader evolution towards continuous wireless non-invasive monitoring, but also how emerging technologies might be reshaping delivery of intensive care in the air. Ina, welcome to the podcast.
Thanks for having me.
Ina, just as we do a deep dive into the subject, I wondered if we could just initially start with maybe, what people maybe fundamentally misunderstand about fixed wing critical care, and retrieval medicine.
In general, we have this wording, it's aeromedical transport. But under aeromedical transport, they're following helicopter transfers as well as repatriation flights. So when we talk about transport and medicine, we have always to define that it's fixed wing and not a rotary wing. The differences between this both is easy because you have a helicopter that goes for short differences, most of the time for high acute emergencies. And you have in the fixed wing, you have longer flight times and you go cross borders with dedicated air ambulance aircrafts, fixed wing. This is the difference. The helicopter and emergency service is organized by the country itself, or like in the US by the states. It's falling under their jurisdiction. The global repatriation flights are coming mostly from insurances or governments or private requests when somebody needs to be transported back home or to a better place of treatment.
So just looking at those repatriations, and especially for fixed wing repatriations where there is significant altitude, Could I get you to maybe unpack for us and indeed for listeners, what some of the physiological changes that occur that, really move from that theoretical to the real clinical problems at altitude in that critical care patient?
The thing is just to come a little bit on the ground is we have no research. We have no real huge backed up data to can definitely say that we do harm or we don't. We can just see when we look to the gas laws that there must be some problems. So we anticipate it can be a problem. Just take out a pneumothorax. So the pneumothorax is diagnosed on the ground, the CT scan or the ultrasound, blah, blah, that shows there is something. Then somebody puts a chest drain in. And then the problem is solved on the ground. But what will happen when you bring up this patient up in the air? Do we need to fly in the sea level? Or can we go up because there's a chest drain in place? This is still not clear. There is no study existing. Even the surgeons are just asking for when is my patient fit to fly, actually. And there's no answer to it. So coming back to this, we need data. We need the real research. What needs to be done, and then we can say, okay, we do no harm because we found out on 1,000 patients we have flown that it's fine to go up on 36,000 feet, or we need to stay at sea level. That might be the conclusion. So coming at this point, we need, when we take our patients in the air, they are critical, we need a complete monitoring. This is actually done by the monitors there around. It's like Corpulse or Zoll. That's the most used. So you can get also the blood pressure with the arm cuff, but nobody really tested it if it's fine in a Learjet 30, 35 and 36 or 40,000 feet because they are flying high. Is this accurately working? And coming then back to the crew qualifications, because we have not this subspecialty for aeromedical transport medicine or for repatriation retrieval medicine in mandatory in the medical world. So every specialist, it can be also dermatologist or an eye doctor, they can fly an ICU patient. So, and they are not capable to place an arterial line, and they never have learned to interpret the haemodynamic changes. So we have several problems in aeromedical transport fixed wing, what we need to solve. So I think this is a complete new field. We are on a green field. And ICARUS is just stepped up to say, hey, we want to fill it, and we look for collaboration. We are not a competitor, we are not an organization, we are just a professional association and getting people together to solve this different problems, getting knowledge, getting trained on this environment. And when we will bring patients up, we have a lot of unknown things like G-forces, like pressure, like the gas laws. And when it comes next, the whole logistics. So when we as medical persons step up in an aircraft, do we know this aircraft is safe? Because you have to trust the pilots, you have to trust the companies that they're doing a good job. But you are stepping in as a doctor or as a nurse.
To your point, there's multiple stressors at play at altitude, but it's not just the altitude, as you say, it's the longevity of the transfer. Because, if you have a super sick critical care patient and you're with them for maybe 4 or 5 hours, or indeed an international repatriation, there is that hypobaric hypoxia. There's the vibration, there's the acceleration forces, there might be the gas expansion. But in my prior life, when I used to work in British Columbia and we did some long retrievals back to VGH, Vancouver General Hospital, it was generally what caught me out, or what was the emergent need was the CRM, the crew resource management. So just getting good comms between the aviators and the medicine. So that actually, if there was any emergencies or any challenges, there's good interaction pre-brief and post-brief, and there was, we start to troubleshoot things together as a team. So there weren't these almost isolated teams. Could I get you to maybe either speak to that or what you see as the most underestimated aspect of this specialism?
Yeah, as I said before, you step in an aircraft. This is not your common workspace. Normally you go in the hospital or you sit on an emergency car, but there you go in an aircraft. You have to trust the providers that everything is fine, and then you have to build the team with the pilots. And you need a deeper understanding how this is working. Why is the weather affecting me? Why we can't land now? But because I need to land, we have a problem. And now the pilot's just telling me, no, it's super foggy. We have to look for another airport where we can land. So this understanding needs to be teached to people they want to do the job. And when you're normally, like you said, you flew in British Columbia, you had an experienced doctor or nurse with you at that time, so you learned from her. But nobody briefed you what it really means when you're up in the air. And this is space, where you sit with the pilots. And then with the super sick patients, this is an environment. This is completely new when it's your first times. I'm just busy in it for a long time, and I'm always learning. I'm always learning, and it's super important that you build the team with the front and the back. I had once a flight to the Cape Verde where a patient was getting super sick during the flight, but as well my flight nurse. So this was a challenging moment because I was struggling with severe arrhythmias and for the patient, and my flight nurse, he was just passing out with fever over 40 degrees because of the tonsillitis. And and we were over the ocean, so there was no way to get out. You have to act. So the co-pilot said, okay, I'm coming over and I'm helping you what I need to do. So we both were treating the patient and the flight nurse. Can happen. Everything went fine, but in the time when it occurs, it was a high stressor.
So Ina, in a helicopter or indeed a fixed wing aircraft, could I get you to maybe unpack for us, how reliable our conventional monitoring tools are?
The thing is, you have to trust the monitor, and most of them, they have the D160G certification. So when you're a doctor and not a deep medtech specialist, then you have to trust what they're saying. When I'm flying ICU patients, then I'm always thinking, can I trust this cuff, this arm cuff? And most of the time when I think of it, I'm just replacing the arterial line because this is accurate. You get it directly. I never compared, to be honest, the cuff with arterial line. This could be a next step. What we really can do with ICARUS, just start a project to see what is better working. I think continuous hemodynamic monitoring during a flight would open a lot of doors and will answer a lot of questions when we start doing it.
Could I get you to maybe speak to, how that physical separation changes the way you assess, anticipate deterioration, and even, in a way, intervene in flight?
The thing is, just to look for one case, if you have an HB under 8, and if they're telling you on the ground the patient is transfused several times before, then my alarm clock's just going because it will come to hypoxia. because of the low HV. And the things I'm always doing on the ground is refusing a patient under 8, because we need more than 8 to transport the patient at altitude. Secondly, when it's over 8, like 10 or 11, and they said, this was a massive transfusion of 20 units of blood or whatever, then I'd be cautious, because maybe he was stable the last 2 days, no new bleeding, and then I place an arterial line and do a complete hemodynamic monitoring to see what will happen when we go over sea level. And if this is getting worse, then we have to go back to sea level. And my information to the operations and my information to the crew will be, in this moment, we have a critical patient, and it might be that we have to do this flight in a sea level flight. What this comes on the other side, that means they have to do maybe a new flight plan. They have to do rerouting, because if you fly sea level, then it's you have longer flight times and you have more refueling during the time, because you burn more fuel as lower you fly. But this is not medical knowledge, this is just the aviation side. But this is a consequence when I'm telling them, okay, we have to go down. But from the medical point of view, it's that you see a patient, and with a lot of experience, what's now with me and in me, I can just detect all the pitfalls, and I can say, no, this one is too unstable. It might cause some trouble, so we have to be prepared for putting vasopressors on, and where is the CV line. And so I detect all the things on the ground, because when you don't put the needles in on the ground, or the caution lines, then you will fail up in the air. The aircrafts are mostly really small, and if you have pneumothorax on the left side, and you're flying with a patient in a Learjet with head to the pilots, you never will put a chest drain in the left side. You never. This won't be possible. So you have to detect all these things before you load a patient, and you have to have the solutions beforehand in place.
So, you and indeed ICARUS has extensive experience in long-range international repatriation missions. But, what are some of the unique challenges, I guess, in a way, that emerge during an 8 or 10-hour transfer compared with a typical HEMS mission? So you spoke to weather, and absolutely I can testify to the dynamic, weather which can interfere with your medical plan. And also it can interfere with medication regimes, with the longevity of medications on a syringe pump or otherwise. But could you get to speak to some of those unique challenges, and I guess in a way how flexible and adaptable you need to be?
You need to be super adaptable and flexible, because you have limited resources. Firstly, the space, as I said, just come to the chest drain. So fact is, you need to put something in. What is your solution? So when you load a patient, then you have to have a solution for the worst scenario. So my one would be, okay, I place a chest drain beforehand, but if it occurs, how I can solve it? Maybe just a needle. Okay, this is capable. And then you go, when you be up in the air and the doors are closed and takeoff is done, and you have a deterioration and in the takeoff time of a patient, you have to be prepared beforehand, so that, for example, the vasopressors just needs to be switched on, that you not start to look in the bags, or where's the noradrenaline, and where's the syringe, and where's the pump, and where's the line, so that you just have it in place and just switch it on. So yes, and the one of the most important things is you have to act as a team. So in my case, my flight nurse must be trained and must be understanding my language when I'm just saying, no, we need to prepare everything for case of, then I wanted my nurses just to have the same thoughts like me, that I don't have to explain everything, and that we are clear and also in all the standards. So how is fentanyl in a syringe pump? How I want to give the propofol or the vasopressors. The team must be good together and have a deep understanding what they do.
So just tracking patient monitoring, over prolonged flights, we say in the podcast and we've said it a few times, no number is really valuable in isolation. It really is about trended data. But could I get you to speak to, maybe occasions where you're tracking the trended data and there is subtle changes which maybe completely alter your clinical decision making? Could I get you to speak to, the way you track trended data and how maybe that alters your clinical decision making or gestalt?
So when we have an arterial line and it's easy to track the blood pressure in the takeoff and landing, and what you see then in the takeoff from the physiological part is that the G forces are just taking place in the patient. When you have a low pump function and you go in the takeoff, you will see that the patient is hypotensive and is on the way to being tachycardic because of the head is up. It's in the direction to the pilot, and the aircraft goes up. So all the blood is going down. And if you have not enough heart capacity, the pump function is not good enough, then it can go into the cardiac decompensation. And in the landing phase, you have the same, because then it's overloaded.
Could you get to maybe unpack and walk us through how much success really comes down to that CRM, that crew resource management, that good communication, and I guess in a way that mitigation of human factors?
You always see that in the worst moments when something has happened. I grew up in a company, they did aeromedical crew resource management. So we were trained in this specifically. And I've also worked in other companies where this was never an issue. And the crews itself, they grew together because they do missions together. And then you see how good it works. But when you go out the team, and if you be in touch then in a real scenario with operations, then you see that the operations never was trained in crew resource management. So we had an accident in the desert where one engine was getting fire, and this was really where it comes in, to the point, crews working together, and the pilot just opened the door and he said, "Everybody out, the aircraft is burning." We never have been trained on it, but we acted correctly. We saved the patient, we saved most of the material. But when we were at the moment when we have been saved, our operations was calling us, and we said, "Oh, they want to talk to us. This is great." No, you know what they ask us? "Hey, can you do tomorrow another mission?" So there was this lesson was never learned. So the operations is not part of this team. It's getting out, and this is a crossroads.
So just looking, something you denote really quite nicely within your answers actually there, Ina, is that you're effectively in the air running an ICU, a flying ICU with a very small team in a noisy and constrained environment, potentially over hours, with a sick patient, which is potentially dying on you, or critical care patients. And it's also you are the consultant, you are the team. You don't have other colleagues to necessarily confer with. I think you've already notioned to the fact it might actually make you a little bit more conservative. So you already start preparing plan A, plan B, plan C ahead of time to try and almost mitigate and error trap some of these mitigations. Could I get you to speak to that?
You have a lot of risk. And at first, when you will get a medical report of a patient, then you check the medical report, and then you have to ask yourself, what if, and then you have to find the solution. I'm trained as an anesthetist, so maybe a lot of you know that you have your airway trolley in the theater. So all your ifs are worked through. You start with a tube, it's a normal thing, it's failing. Then you go for the laryngeal mask, then you go, you have some bougies and so on. And at the end, you need to cut. So this is the anesthetist's training path. So if this fails, then I do this, and I do this. And the same I'm doing with when I take over a patient. So I'm checking the medical report, and I just flag out all the points. And then I'm working through this, through the ifs. The second thing is when I work through the medical points and found a solution, then I have to look, where we are flying to. If we go to a country where's a war zone, what do I need to know from the flight crew? Is it safe there? Do we have a safe transport? Is somebody looking after us? Do we have enough oxygen on board, or do we need extra oxygen? Or what if we are running out of medication or something? You just have to know by the flight route and the destination what can happen and how we can solve it, even from the logistical operational side, next to the medical side.
We finish off on the interview, Ina. Looking ahead 5-10 years down the line, could I get you to maybe walk us through what you feel and think aeromedical medicine might look like? What are some of the key developments, technologically or operationally, or indeed educationally, that might change care in this domain?
What we need, and what will be done, I hope, in the next 10 years, is that that the medical world is accepting aeromedical transport medicine fixed wing as a subspecialty in the training, that the medical world is recognizing what we're doing, that everybody get a proper training before they step in an aircraft, that we will have enough data and access to data to analyze that we're doing not any harm to patients, that we know what we're doing is based on evidence, and that we also have monitoring, and which is my biggest wish, where I don't have to put any needles in, and I get all the data without cables to monitoring, which is working. This is you have, when you load a patient or unload a patient, you have always cable chaos. Everybody knows that, even from ICU to the CT scan. After that, there is a big knot in the patient, and we same have that in the aircraft, but the aircraft is much smaller. So to figure it out, and continuous hemodynamic monitoring would be super helpful when we will have it in the aircraft, that we see every deterioration upfront.
Listen, that's fantastic. And it's just nice to walk through some of these key challenges because, to your point, Ina, getting more empirical data, getting more evidence. So to your point, that you can practice evidence-based medicine in the air, in long fixed wing repatriation, and that it becomes a recognized subspecialty internationally. Absolutely. Listen, it's a privilege to have you with us. Thank you so much for your insights and indeed your answers over this past half an hour. So thank you.
Maybe one little thing what I want to add to the data, because we have in the International Civil Aviation Authorities say it's not written that we have patients or medical crew. So when this is still not in place, we won't get any data of how many patients are transported, how many patients are dying, and we have no recording of any events. So this is another step what needs to be done in the next 5 years, I hope.
Ina, listen, thank you for joining us today. Really, really appreciate it.
Thank you for giving me the chance.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.